Today we are going to discuss about some basic concepts in echo, the hemodynamic assessment. How do we approach in echo about the hemodynamics? So to start with, uh, what are the parameters and what are the main things we look into the echo? So we have volumetric measures. It includes stroke volume and cardiac output. Then we go for regurgitant volume and regurgitant fraction, and then pulmonary and systemic flow ratio. The second part is maximal and mean pressure gradients, various across valves or any defects or any ASD, VSD like things. So we have to see the pressure gradients. Then comes the valve areas, and then intracardiac pressures like pulmonary artery systolic pressures, left atrial pressures, left ventricular and diastolic pressures, etc. So hemodynamics is very important because all these parameters we have to assess on a daily basis, on a day-to-day cases. And moreover, when we have to assess the patient on a non-invasive part, most of the times we can do the part which will help us in avoiding invasive measures. So this is very important. If you can do the thing which they do in critical care, it will be very helpful for the patient also and economical also. So to start with, the basic concept of heart function is cardiac output and stroke volume. So how will we calculate the stroke volume and cardiac output? So flow across any orifice is calculated as cross-sectional area into flow velocity. So this is the basic thing. Now, how will we approach? Sum of velocities during a given ejection period is calculated as velocity time integral. And this is the velocity time integral which is taken as an area. When you multiply with cross-sectional area, this VTI will give you the stroke volume. So to summarize, if you give a pulse wave Doppler at LVOT, you get a graph below the line and you just trace it, that is the VTI. And then you have to measure the cross-sectional area, and if you multiply it, we'll have the stroke volume. Now, how is the cross-sectional area is defined? So cross-sectional area of orifice is of any part is assumed to be a circle. So LVOT area will be just the circle of the area of the circle is pi r square. So pi is value is 3.14, and a square of d by 2 means radius. So if you measure the LVOT diameter, you will get the d, and half of it is the radius. So the half of it squared multiplied by 3.14 will give you the stroke volume, cross-sectional area, and then multiplied by VTI, you will give the stroke volume. Just to summarize, to make it clear, this is the zoomed view of LVOT, and we have to measure the LVOT diameter. It is just 1 centimeter, around 1 centimeter to the part where the aortic leaflets meet. So this is basically just 0.5 millimeter to 1 centimeter below the annulus of the aortic valve. So you measure it, end-to-end measurement. This is the d, and half of d is radius, and you have to calculate the area. So the pi r square is clear. Now you go at the LVOT part. LVOT part, you have to measure the pulse wave Doppler, because we are going to measure the LVOT VTI, not the aortic valve VTI. So for LVOT VTI, you give a pulse wave Doppler at just opening of the aortic valve. You get a trace like this, and you just measure the VTI of this part, and this is the VTI of LVOT. Now VTI of LVOT, if you multiply with the cross-sectional area, but we calculated just with the help of pi r square, you will get the stroke volume. Now when stroke volume is with you, you can just have a count of heart rate, and you multiply the heart rate with stroke volume, and you get the cardiac output. So this is the basic principle by which you can calculate the cardiac output in a patient in just few minutes, You can easily calculate the cardiac output. No need to go for an invasive measurement and no need for Swan-Ganz catheter, etc. You just in a matter of seconds, you calculate the cardiac output, and most of the times we have seen, we have compared with the cath data. This is approximately same. There is no significant difference. So you can rely on this. Now, why this concept is important? So this concept is used in calculating regurgitant volume and regurgitant fraction. As for example, in mitral regurgitation, the mitral inflow to LV in diastole should be equal to the sum of LVOT systemic outflow and mitral regurgitant flow in systole. So MR regurgitant flow will be mitral inflow minus LVOT outflow. To understand this, you have to understand that the blood coming to the LV is equal to the blood coming out of the LV, and if some part of the blood is going back to the LA, means the MR flow, that should be equal to the amount of the blood came to the LV in the diastole. So the amount of regurgitant flow you can calculate by just having a subtraction of the what was the uh, amount of the blood flow which came into the LV and what went out of the LV in the aorta. The rest blood is the MR regurgitant flow. So this is how will you calculate this amount of blood? So for that you have to apply this cross-sectional area into VTI concept. You just get a mitral valve cross-sectional area just like in the previous slide. You get a VTI at the mitral valve. You just multiply it. You get the whole amount of the blood which is coming to the LV. Now you'll have to subtract the amount of the blood going to the LVOT, the aortic valve. The cross-sectional area of the LVOT, like in the previous slide, VTI of the LVOT, you multiply it, you will get the stroke volume or the amount of the blood which is going out of the LV towards the aorta side. So the amount of the blood, whole blood coming to the LV and amount of the blood going to the aorta, you just subtract. Suppose 100 milliliter is coming in the beat and 60 milliliter of blood is going through LVOT. The rest 40 ml is the MR regurgitant flow, because amount of the blood is constant per beat. Suppose 100 ml is coming to the LV, the same has to be given out of the LV. So by this simple calculation, we can calculate MR regurgitant flow. And by calculating MR regurgitant flow, we can quantify the severity of the MR. So this is the one of the basic concept of that hemodynamics. Now again, the same concept comes in the shunts like ASD, VSDs, where we have to find out what is the percentage of the blood which is going to the pulmonary part and what amount of the blood is going to the systemic part. So you have to calculate the QP by QS, and on this basis we have to define whether we have to go for a surgery or not, or surgery is feasible or not, or is there an Eisenmenger going on. So to assess all this, we need this QP by QS. Now again, how will you calculate the QP and QS? Same concept here again. QP is calculated by cross-sectional area of the RVOT. RVOT's view is short axis view when you go for a big artery level, you short axis, you find the pulmonary valve, and you just put pulmonary pulse wave Doppler at the opening of the pulmonary valve. You will get a RVOT VTI. You have to just measure it, trace it, and you will get RVOT VTI. And the same concept which we applied in the LVOT area, you apply with the RVOT diameter, and half of it is D radius and pi r square. That will give you a RVOT cross-section area. Just multiply it, RVOT cross-section area and RVOT VTI, you will get QP. QS, same as we discussed earlier, cross-section area of the LVOT and VTI of the LVOT, and you will get QS. Now the ratio of the QP by QS you can easily calculate. So this is the other use of the same concept of the hemodynamics. Now this some words about the continuity equation. We'll always use continuity equation in assessing the valve areas. So what is the basis of the continuity equation? The basis of the continuity equation is the amount of the blood is constant by passing through a tube-like pattern. So where the area is large, the volume will be less, and where the volume is large, area will be less. So this is the concept. This is the flow hemodynamics, which is the concept of the physics. So given in a part, if you consider it as a continuity tube, the area and the VTI will be one part will be equal to the area and VTI of the second part. Suppose the area is the LV and VTI of LVOT, and A2 is the aortic valve area and VTI of the aortic valve area. So if any three of the four are known, we can calculate the fourth one. So in this, where A2, we can have a regurgitant or stenotic orifice area, and A1 is the upstream flow like LVOT. So in LV, for understanding this example, you take an example of aortic stenosis. So in aortic stenosis, you apply this principle and you get that LVOT area into LVOT VTI should be equal to aortic valve area into aortic valve VTI. With this concept, we can easily calculate the aortic valve area. So LVOT area, again the same concept, the cross-sectional area into VTI of the LVOT. VTI of the LVOT, and cross-sectional area, you know, pi r square, you just get diameter and half pi r square you calculate, and take a pulse wave Doppler here. The only thing you have to keep in mind that LVOT VTI must calculate in the pulse wave. If you apply continuity wave, it will go for AV VTI, because this is the basic difference of the pulse wave and continuity wave, because in pulse wave you take an instantaneous point specific measurement. So this is the LVOT VTI where you apply pulse wave. So LVOT area into LVOT VTI you have AV VTI, you just apply continuity wave at the aortic valve area in 5-chamber view, you get a graph below the line, you trace it, that will be the AV VTI. Now AV VTI you have, LVOT VTI you have, LVOT area you have, you can easily calculate AV area, and that will be aortic valve area by continuity equation. So this is the other concept of the continuity equation. Now coming to the pressure difference part. Pressure difference part is basically based on the Bernoulli's equation. So what is Bernoulli equation? Bernoulli equation is defined as the pressure difference between the two orifices, two part of the orifice, and that defines as 4 into square of velocity. The V is the transvalvular velocity gradient. So basically the velocity difference between the two part of the orifice is calculated as V, and we take 4V square, that gives you the pressure difference. Now where this Bernoulli's principle is applied? So we have to apply this principle in these situations. This is very important to understand that peak TR velocity, we have an idea of RV systolic pressure or pulmonary artery systolic pressure. Peak PR velocity, we get mean PA pressure. End diastolic PR velocity, we get PA end diastolic pressure. So where how you use it, you just have to measure either PW or CW. The basic difference is that where you get low velocities, you use pulse wave Doppler, and where you get high velocities, you get continuity wave. Like peak MR velocity, you will go for continuity wave, and peak TR velocity you will go for continuity wave, but peak PR velocity you can go for pulse wave. If velocity is beyond Nyquist limit, you will go for continuity wave. So you just take the peak of the measure the peak of the graph, and you get peak PR velocity. Same is peak TR velocity, same is end diastolic peak PR velocity. You have to know where you have to apply pulse wave and where you have to apply continuity wave, and you go at the peak of the tracing, and you get all these things. Only you know where you want to apply it and what you will get. So again, you have, if you want to know peak MR velocity, you will get LA pressure. If you measure end diastolic AR velocity, you will get LV end diastolic pressure. If you go for mitral inflow velocities, you will get LV EDP and LA pressures. So with these measures, you can easily make a very good assessment of cardiac parameters, and with which you can help yourself or your clinician to plan disease management or treatment strategies. Now, coming basic concept of the diastolic dysfunction, you all know that in diastole, if you apply pulse wave at the mitral inflow pattern, you will get a first E wave and the second A wave. So with this E wave and A wave, you get diastolic dysfunction parameters, and with this you can understand the symptomatology. This is very important because many a times EF may be normal or EF may be low, and with this diastolic dysfunction parameters, you decide about the treatment pattern, and many a times you decide about the cardiac disease as such, because you know the diastolic dysfunction is the first thing which is going to be affected in a cardiac condition like MI or angina. So if there is diastolic dysfunction, uh, you must get cautioned that your treatment strategies should be changed or taken care of the condition of the patient. So what are the different parameters and what are the different stages of the diastolic dysfunction? Just going through the basic, you all know the normal is E is greater than A, grade 1 is E is smaller than A, third is grade 2 diastolic dysfunction is pseudo normalization, where you again get E is greater than A. But where will you define that whether it is pseudo normal or normal? So here comes the tissue Doppler. I will explain the next slide. And the fourth one is E is quite larger than A. This is the ratio maybe 3 or 4. E or A ratio is more than 3. So this is the tissue Doppler. Here the tissue Doppler we apply at the medial annulus of the mitral valve, and it gives you the just like E and A, but it is on the lower side. So this is the tissue Doppler imaging, where you get first is E prime and second is A prime. So with the ratio of the E prime and A prime and the E wave and A wave, you decide that whether the diastolic dysfunction is of grade 2 means pseudo normal or normal. Just to summarize, you get this normalized diastolic dysfunction grade 1, grade 2, grade 3 and grade 4, etc. Grade 4 is defined as two different parts, that whether it is reversible or irreversible. That is defined on the basis of Valsalva maneuver, but that I will not go into detail. I'll just summarize the E prime and A prime. What is the crux of the slide is this is the E by E dash. E by E dash you have to define. If E by E dash is less than 10, this is the normal. If E by E prime is more than 10, this is pseudo normal. So this is the basis of the defining of the normal diastolic dysfunction, normal diastolic function, and pseudo normal diastolic dysfunction. You have to define it. I'll not go into the pulmonary venous flow if unnecessary. That will make things lengthy. Now, so again the same thing. Septal E prime and lateral E prime. You have to. There is a different parameters by which you can understand that whether this is normal or abnormal, but the crux is the same, that you have to go for the E by E prime ratio. If it is less than 10, it must be normal. If it is more than 10, it must be abnormal. There are some differences in this, but going into the detail will not serve the purpose. The basic concept should be clear. Now again, just going for the RV and LV ratio, to summarize in hemodynamics, you have many a times they ask if the RV is dilated or not. So just to summarize, if the normal RV area to LV area is 0.36 to 0.6, moderate RV dilatation correspond to an RV-LV ratio between 0.7 and 0.9, and severe RV dilatation results in an area equal to or greater than of the left ventricle. Now, just to summarize these concepts, I have few questions that is very interesting. Let's see if you answer it or not. So, if patient is having BP of 120 by 80 millimeter of Hg, his peak MR velocity was calculated as 5 millimeter per second. Now, if you calculate LA pressure with this, if you calculate, please tell. So, how will we calculate? With this information, if your critical care partner asks you that patient is having BP is 120/80, you have an echo machine, I just need to know LA pressure. Suppose patient is having MR, AF or anything, and there is no invasive measurement. How will you go with echo and ask uh, help him in ascertaining LA pressure? So this is very simple. You just take pressure difference by Bernoulli equation. You go for 4V square. The pressure difference is 100 millimeter of Hg, because we have 5 millimeter of Hg. If you go the previous slide again, 5 millimeter of per second was the MR velocity. So this is the difference. 4V square, you remember, 4 into V2 minus V1 square. So V2 minus V1 is the difference of the velocity. So peak MR velocity gives you the difference, peak of the velocity difference between the pressure difference between the LA and LV causes the difference in the velocity also. So this is the difference in the velocity, and if you take the difference into the velocity into the consideration, 4V square, you get the pressure difference. Now pressure difference 100, you have systolic pressure, you have 120 millimeter Hg is the systolic pressure. So this is the peak pressure of the LV. Now you have the pressure difference between the LA and LV is 100. So peak LA pressure will be simple, 120 minus 100, 20 millimeter Hg. So your answer will be 20 millimeter Hg. So this is the basic application of the principle of the Bernoulli equation. You, with the help of the echo machine, you just go and say that, boss, this is the pressure difference of 20 millimeter Hg. So the LA pressure will be 20 millimeter Hg. Now again the same equation application in a different scenario. If patient is having 140 or 60 millimeter Hg of blood pressure, in 2D echo you get AR end diastolic velocity was calculated as 3 meter per second. Now how you calculate AR end diastolic velocity? You just apply continuity wave Doppler on the AR wave. You get a graph up to the line. You just go to the peak of that part, ending part, you get the AR end diastolic velocity. Now that is, suppose that is 3 meter per second. Now the clinician want to know what is the LV end diastolic pressure, because of ascertaining the causes of LV dysfunction or dyspnea. So how you will go for it? Again, the same concept. You go for the pressure difference. Pressure difference is equal to 4V square, where V is the velocity difference. Velocity difference with this slide, you get AR end diastolic velocity is the velocity difference in the diastole. So AR end diastolic velocity is 3 meter per second. If you calculate 4V square taking into 3, you will get the end diastolic pressure difference between the LV and aorta. So pressure difference will be 4V square, 36. Now the diastolic pressure is the pressure in the aorta in the diastole. So that is the 60 millimeter Hg diastole, because we know here the BP was 140 by 60. So diastole it was 60. You have pressure difference in diastole 36. Now what will be the pressure difference between the LV and aorta? So that will be the LVEDP. You just subtract this pressure in the aorta and the pressure difference between the LV and the aorta, you will get the LV and diastolic pressure, that is 24 millimeter Hg. So with this you easily understand that the LV and diastolic pressure is 20 millimeter Hg. Then you will see that if this should be decreased or this should not be decreased, this is adequate. Depending upon that, you just titrate the antihypertensives and other medicines also, and to assess many a times LV dysfunction is there is LV dysfunction and you need to start some Vimada like drugs. You just want to know these parameters to ascertain the dose and timings. And many a times you need to withdraw the drugs then to decide whether we should withdraw a drug or not. Then you need these parameters. If you get the help of these parameters, your decision will be comparatively better, and that will be clinically the outcome will be better. Now, just to give a twist to the question, we have going to the question number one. Again, peak MR velocity is 5 millimeter per second. Here, BP is 90 millimeter Hg. Now, 4V square, you give 4V square, the pressure difference is 100 millimeter Hg. So LV and LA pressure difference is is 100, and systolic blood pressure is only 90 here in this patient. How is it possible? So is there any abnormality in this equation? What is the problem? Where it is? So what is the explanation that if the pressure difference is 100 and systolic BP is 90, how it can be possible? It cannot be negative. So the answer is LV obstruction, LVOT obstruction. So the thing is that the pressure difference, the pressure in the LV, which is measured by the BP apparatus, is high, but the pressure in the aorta, which is measured by the 4V square Bernoulli's equation, is low. Because of the LV obstruction, the pressure is not transferring, the LV pressure is not transferring to the aorta. So if you get this condition, you can help with this simple measurement. You understand there must be some LV obstruction. Many a times you don't get clear-cut aortic stenosis. Many a times there is subvalvular thickening or subvalvular structures of or membranes, which is not clearly visible in 2D echo. You go for TE and then only you find that there is subvalvular membrane causing LVOT obstruction. So to make your diagnosis a bit precise, you apply this Bernoulli's equation and you suspect that there must be some obstruction to the LVOT. We should measure it, and we should go for a TE to ascertain that whether there is a LVOT obstruction or not. So this is another use of this Bernoulli's equation. Now, just to summarize some other important parameters where you can use hemodynamics is systemic vascular resistance. Many times in critical care, you need to understand what is the systemic vascular resistance, because with this you have to decide about the inotropes, the dosing of the inotropes, the choice of the inotropes, and the response of the antibiotics to the sepsis. Whether patient is sepsis is getting controlled or not, you need systemic vascular resistance. So the critical care people use this all Swan-Ganz catheter apparatus, all these central monitors to ascertain this, but with simple echo you can measure this systemic vascular resistance, that is the mean arterial pressure minus central venous pressure by cardiac output. Now mean arterial pressure, you easily calculate systolic pressure plus 1/3 of the pulse pressure. Central venous pressure is your RA pressure with IVC measurement. You measure for the central venous pressure, and cardiac output, as I explained you earlier, with this stroke volume multiplied by heart rate, you just simply calculate the cardiac output, and you apply this equation, MAP minus CPP divided by cardiac output, you get systemic vascular resistance, and most of the times this is approximately correct. So there is no much difference between the cath parameters and echo parameters if you apply these things correctly. Now again pulmonary vascular resistance. Many times in recent COVID times, there is patient is having breathlessness with no explanations. There you have only thing, you get high pulmonary vascular resistance, but you want to avoid invasive measurement. How will you go for non-invasive measurement? Very simple. You just apply this equation. Pulmonary vascular resistance is equal to Vmax TR divided by RVOT VTI. The sum is multiplied by 10 plus 0.16. Now, how this Vmax TR is calculated? Again, the same principle. TR is high end velocity. So you just apply the continuity equation, continuity wave at the tricuspid valve. You get a large T-shaped graph or tracing. You take the peak of that is the maximum velocity of the TR. You just note it down. Again, you go at RVOT in the short axis, you at the pulmonary wall level, you apply pulmonary pulse wave at the pulmonary wall, you get a graph there, you trace it, that is the RVOT VTI, you divide it and then multiply with 10, and you have to add is a 0.16, and this is calculated as good units, and this is most of the times it is correct up to 8 Wood units. Again, PVR is very important in deciding in ASDs whether you need to go for a device, whether you should close the ASD or not. Many a times closing the ASD is detrimental in congenital conditions. So there you need to know pulmonary vascular resistance. Your invasive colleague and the CTVS people want to know what is the status of the pulmonary vascular resistance to decide about the treatment strategy and deciding about the surgery, go for it or not to go for it. They ask the eco people that what is the whether we should go or not. So you should have an answer, and to get an answer you just apply this equation. You calculate PVR. If it is very high, you just said that pulmonary vascular resistance is very high, the surgery is not indicated or not advisable from eco side, and the rest is clinically decided. So with this you can easily calculate and help your colleagues to decide about the treatment strategy as well as treatment effect. So the 2D echo is just not about calculating the EF only. As you see, this is very helpful in deciding treatment strategies, in deciding treatment response, and in making things helpful for the critical care people also to understand the hemodynamic parameters, to decide about the fluid balances, fluid therapy, any invasive procedures, choice of the inotropes, etc., etc. To summarize, what you go in and see in the patient when patient is in critical care or in emergency or just in your OPD. So to summarize, you have to 3-4 conditions where you have to stress. First, you have to see hypovolemia. So if it is hypovolemia, there will be significant collapse of the IVC, and the causes will be volume losses or severe vasodilatation, internal bleeding, etc. Implications will be volume expansions, vasoconstrictor for primary distributive problem, inotropes of use of inotropes in sepsis, etc. So you simply see IVC and you tell that patient the treatment of the patient should be in that manner. Again, if LV is down, impaired systolic function, then you listen if there is a reasonable motion or global hypokinesia or a dilated IVC, no low cardiac output or low urine output, you just see that the patient is in cardiac shock, cardiogenic shock, and then you decide about the inotropic support evaluation for CAD or left ventricular failure, and accordingly decide for the treatment strategy. Again, coming to the RV part, if there is RV failure, you go for and see that whether RV size is equal or larger than LV size. If it is larger, you suspect pulmonary embolism or other parameters which is beyond the scope of this discussion. We'll discuss it. It's later different meeting. So then again you go and consider if this is P, that is in emergency room many a times, especially in COVID times, you get and see that P is very evident nowadays. So you go and evaluate for the pulmonary embolism and you go for CTP and decide for a thrombolysis. Again, if there may be tamponade, very large number of cases coming in sudden onset tamponade in post-COVID era. Again, you have what you will see the pericardial effusion. You will have to see atrial collapse or RV collapse. Disease of the pericardial diseases, whether this is pericardial disease or any other disease leading to cardiac tamponade pericardial effusion, and then decide whether you have to go for pericardiocentesis or not, or conservative management. So this all about synopsis about use of hemodynamics in echo. I think this is a very big subject. I try to make a conclusion of the crux of the thing. If you want any question, please ask.